and so on and so forth. So it's a very important topic to deal with. So, as I said, it's extremely prevalent. So worldwide, it is estimated that 1 billion individuals have hypertension. It carries a high mortality, more than 7 million deaths per year that can be attributed to hypertension. In fact, it is the leading cause of death worldwide because it is so prevalent. So even a smaller percentage of mortality in a huge population who has hypertension will mean a high number of deaths. It is more frequent in economically developed countries because of the risk factors and the features that are associated with it. People in developing countries, in poor countries, they tend to die earlier from other diseases, but in developed countries, it is quite frequent. In Romania, we don't have very strong data, but the last information we had from a study that was run was that the prevalence is about 40%, again, very high. And of course, it increases with age. You can see here the prevalence of hypertension in adults over the age of 20. And you see if this is more uncommon in the young ones. And it is a predominance of men over women. Progressively with aging, the prevalence of hypertension increases. And then around 60 years of age, there is a reversal, and then you have more women than men having it. There is a protection, a hormonal protection, among other factors, that is responsible for this man predominance in younger individuals. But then after menopause, this gets equal and even reversed. What you can see here is that this is virtually very in almost every individual above the age of 75 will have hypertension. So it's an extremely important topic. This is also another crucial slide for you to see, because the problem is that, first of all, people are not aware that they have hypertension, because in many instances it is asymptomatic. You may have 170 and you don't feel anything. So if you don't screen, if you don't measure the blood pressure, you may miss those and still get the complications. So awareness, okay? Percentage of population with hypertension, awareness. And of course, as you can expect, the awareness is lowest in the younger ones, because if you are 30, you will not measure your blood pressure, only accidentally. If you are over 60, you have, more often controls, and you see this. So there is a difference between aging, but anyway, the awareness is around 50%. Secondly, those who have hypertension and get treatment, things are even worse. And they may have hypertension which is untreated. Again, pretty high percentages. And finally, we don't just need to treat it, we need to control it. We need to treat it effectively and to bring the blood pressure within the expected target range. And this is really bad. You can see here, just a minority of the hypertensive patients get properly controlled blood pressure values. In other words, they are exposed to the negative consequences of hypertension. So there's a huge problem, and there is a huge room for improvement with respect to the proper treatment of the disease. A few things of pathophysiology. Again, not a lot, because you had this specifically in the third year. But anyway, The key features for blood pressure values are cardiac output, the amount of blood ejected by the heart on one hand, and on the other hand, the peripheral resistance. So the blood pressure is the product of these two factors. So you may have increased blood pressure values either by having an increased cardiac output, or by having an increased peripheral resistance, or by having both of them increased. And this is important to remember because the targets of treatment are related often with one or the other of these factors. We can decrease the blood pressure values either by decreasing peripheral resistance or cardiac output, or both, okay? But anyway, the peripheral vascular resistance is the hemodynamic factor mainly responsible for persistence of hypertension. It tends to be the most important. What happens then if you have high blood pressure? There are a number of consequences which are deleterious in the long term. There is myocyte hypertrophy, so the ventricle has to pump against an increased pressure in the aorta, and therefore it tries to adapt, and it adapts by developing hypertrophy. And it's not only myocyte hypertrophy, there are also changes in the interstitium, fibrosis development, there is a reduction in flow in the intracardiac vessels, there is endothelial dysfunction, and also there is, to a larger extent than in normal blood pressure patients, epicardial coronary disease. So it comes with a number of consequences that lead to the pathophysiological changes that will be the hallmarks of complications in the long term. In terms of mechanisms, there are a few things to highlight. So mechanisms are multiple, complex. The interaction is very important between them. And we say that most of the patients who have hypertension is multifactorial. So it's very difficult to pinpoint one single mechanism and target it and solve the problem, because it's a number of factors, multiple, interlinked, and influencing each other, that keep this blood pressure high. However, we can try to reduce some of them that we know come with increased blood pressures. So on the right hand here, you have a number of factors that are hypertensinogenic. In other words, they promote high blood pressure values. Obesity, high alcohol intake on a regular basis, high salt intake, sedentary lifestyle, stress, dyslipidemia. So, of course, among the measures we take and the recommendations we give to these patients are reductions in some of these factors that could help decrease blood pressure values. The genetic factors, we have some features that highlight the importance of this. For example, there may be concordance of blood pressure values between monozygotic twins as opposed to heterozygote twins. So there are a number of things. However, a monogenic disorder that leads to hypertension by means of influencing salt and water dealing by the nephron, this is quite rare, and it's a number of syndromes that have been described, but these are pretty rare. Neural mechanisms, most pronounced in the younger adults. So in these cases, hypertension goes with an increased heart rate and cardiac output. There is an increased levels in the norepinephrine. And these patients are often obese. It may be seen in the early stages of type 2 diabetes, chronic kidney disease, or heart failure. And also the link with sleep apnea represents a solid evidence for the involvement of neural mechanisms. So these patients who have sleep apnea, they often have hypertension, they often are obese, they often have problems with oxygenation, and these are linked and the neural mechanisms are involved. Among the most common mechanisms involved in essential hypertension are the renal mechanisms, because the kidney is key in regulating blood pressure values. So one of the mechanisms could be the kidney's inability to excrete the excess sodium load in patients who have a high salt diet. The pressure sodium excretion curve may be shifted to the right. That means that the same amount of sodium may be excreted at the higher blood pressure values. So you need higher blood pressure values for a longer time to eliminate the same amount of sodium. There may be renal sodium retention leading to increased fluid volume, therefore increased cardiac output, and then enabling autoregulatory mechanisms that increase the systemic vascular resistance. And also there are vascular mechanisms related to several features: endothelial dysfunction. The vessels are unable to dilate properly, and nitric oxide and endothelin are among the factors that are changed here and lead to endothelial dysfunction. There is then a vascular remodeling. So the hypertrophic response that I've told you about at the heart level, this may also be present at the vessel level, at the vascular level. So the media tends to thicken, and this leads to an increased media to lumen ratio. There is a hypertrophic remodeling of the vessels, blood vessels. And finally, not only the structure of the vessel may change, but also its function. So it may be less compliant, it may be stiffer, and that induces changes in the way that the pulse wave travels and the blood pressure behaves. Hormonal mechanisms are also important, and here a key one that we've discussed also when we discussed heart failure is the renin-angiotensin-aldosterone system, and this leads to vasoconstriction at the level of the resistance vessels, stimulation of the synthesis and secretion of aldosterone, stimulation of the tubular reabsorption of sodium, and effects on the nervous system like ADH release and increase in the sympathetic tone. So, as you could see, there are a number of mechanisms, quite complex, quite varied, and involving several organs, from the heart to the vessels to the kidney to some neurohormonal systems, and it's quite complex, and it's usually a combination of some of these factors. Now, going on to more practical things. Blood pressure measurement. So here you have some of the recommendation and tables from the guidelines on hypertension that I will also send you. And there are a number of principles. How should we measure blood pressure? First of all, the patient needs to be seated comfortably and quietly for at least 5 minutes, not just measure the blood pressure after he came rushing into the office. Secondly, you need 3 measurements recorded 1 or 2 minutes apart. And if the first 2 readings differ significantly, you will do additional ones, because what you need to do is you need an average of at least 2 readings to have a more robust measure of what exactly the blood pressure means. Additional measurements will need to be performed in patients who have unstable blood pressure values. This is especially an issue in patients who have irregular rhythms. Most commonly is atrial fibrillation, because then depending on the moment when you measure, you may find quite different blood pressure values. So then you will need to do additional measurements and to make an average of more measurements in order to have a robust average for that. Then it's very important to have concordance between the size of the bladder cuff and the size of the arm. Okay, so if you have an obese patient, you will need a larger cuffs, and the opposite, because otherwise, if you use a small cuff for a very large patient, you may have spuriously higher blood pressure values. So you will need to adapt this to the patient. Then you need to position the cuff at the level of the heart. Okay, so this is very important that it's at the same level with the heart. The back and arm need to be relaxed to avoid muscle contraction, which may change the measurement. And then, as you know, you inflate and you slowly you inflate the pump until you don't hear the sounds any longer, but then you slowly deflate, and the first moment you hear the beat, that is the systolic pressure, and then you go slowly until the sounds disappear, and then you have the diastolic pressure. Another important thing, you need to measure blood pressure in both arms at the first visit to know if there is between arm differences. And then once you did that, you will use the arm with the higher value as reference in follow-up measurements. Sometimes if you detect a significant difference between the two arms, this may be a hint that the patient may have a stenosis of a subclavian artery, and so the stenotic vessel will give a reduced blood pressure in the respective arm. Also important to measure blood pressure after standing from a seated position in order to exclude orthostatic hypotension. This is especially important in people who have diabetes, in elderly patients, in patients who are hypertensive but describe dizziness or other symptoms that may be related to low blood pressure. So you have the patient lying on the bed and you measure, I don't know, 130. But then if you have the patient standing and you measure, and you may find up 90, so a quite significant difference, that means orthostatic hypotension. It may be related to the patient's symptoms, and you may need to change your treatment in order to avoid that for a number of reasons. So these are the principle of measurements. Who does the measurements? It can be done by the doctor or the nurse in the office, in the clinic, whenever they meet the patient. It can also be done by the patient at home, provided that the patient got proper instruction about how to do it. It may be done automatically over a longer period of time. This is called ambulatory blood pressure monitoring, usually for 24 hours, because this gives us important information about the way blood pressure behaves in a specific patient. So usually in the office, we do, again, I tell you again, at least 2 measurements per visit. And in the initial phase, we may wish to have at least 2-3 visits every 2-3 weeks to have a background, a baseline assessment to begin with. Of course, if the patient has significantly increased blood pressure measurements, then even a single measurement is enough. And the importance of 24-hour ambulatory monitoring is because this also correlates with the organ damage, with the damage that the hypertension provokes to the various key organs, and we'll talk about that in a minute. It also provides useful information about the way blood pressure behaves during the day compared with the night, diurnal, nocturnal profile, how much it is in the morning, because all of that, first of all, relate to some prognostic features and, very important, may lead to changes in the way we treat the patient, which type of drugs we give, at which moment of the day we recommend that the drug is given, and so on. So the normal response for blood pressure is that this will fall by 10 to 20% during the night. So there is a dip, there is a reduction. This we'll call a dipper pattern, and this is a normal response because during night, during sleep, blood pressure gets reduced, heart rate gets reduced, metabolic demands is reduced, and that's why. However, when this is not the case and we find higher blood pressure values at night, this is called a non-dipper pattern, so it does not decrease during night. This is related to an increased cardiovascular risk. So when do we recommend ambulatory blood pressure monitoring? Whenever there is a big variability in the office blood pressure values, and then we don't know if this is related to the stress on the patient because he comes seeing the doctor, and then you want to see what happens in 24 hours in the normal conditions of the patient in his home environment. Whenever you have high office blood pressure, and this does not really match with the level of cardiovascular risk. Whenever there is marked discrepancy between the pressures measured in the office compared with home, the patient tells you, you know, at home I always have normal values, but then in the office you see always high values, and then you want to see what is true. Whenever you give a treatment and treatment doesn't seem to work, so you suspect resistance to drug treatment, you want to see if this is really the case. If there are episodes of hypotension, again, I'm telling you, especially diabetics or elderly, or a very specific situation, pregnant women with high office blood pressure and suspicion of preeclampsia. Now, let me take you a little bit into the risk, into the global risk of a patient with hypertension. Why is this so important? Because all the organs get blood through the vessels, right? And so if the blood pressure is increased in the vessels, this may affect a number of organs, all of them, including some key ones with very bad consequences. So it may lead to stroke, it may lead to kidney failure or renal disease, it may lead to peripheral vascular disease, coronary artery disease, as we've already discussed, and then at the level of the heart, it develops left ventricular hypertrophy, and this may lead to congestive heart failure. So all in all, it gives a lot of morbidity and potentially a lot of disability. So this is why it is key to think of all these organs, and when you assess a patient, try to see the level of involvement and the stage of the way that these organs may be affected. How we define hypertension? How do we classify it? First of all, we talk about a continuous variable. So blood pressure is not something black and white. It's not something yes and no. It is a continuous range. And so we know, first of all, that even in the normotensive range, there is a strong and continuous correlation between the blood pressure values and the risk of cardiovascular events, even in the normotensive range again. So the problem is that whatever we take as an arbitrary cutoff value, we will need to think of pros and cons. We will need to think of a level above which treatment would do more good than harm. Okay? So this makes it a bit tricky and led to lots of controversies. And this is a wise statement. You see, it's 50 years ago, and it still holds true. So first of all, we have a continuous relationship between blood pressure level and cardiovascular risk. And then, of course, as a consequence, this will make any cutoff values and hypertension classification by specific numbers arbitrary. So you need to keep in mind this principle. Moreover, blood pressure is quite different depending on the number of features. The site where you measure it, it's different home compared to office. The moment measuring it, it's different daily compared to night. And it's different when you measure once, it's different when you do an average. So hypertension may have different definitions according to these specific settings. So generally, and this is again from the 2018 guidelines of the European Society of Cardiology, there is a grading, and we call optimal blood pressure values below 120/80. This is optimal. This is ideal. We may call it normal, 120/130/80 to 85. We may call it high normal already, 130/140/85 to 89. And then you can have grade 1, grade 2, and grade 3 hypertension. And this is easy to remember because it goes in increments of 20 millimeters the systolic and 10 millimeters the diastolic. 140 to 160, 160 to 180, above 180, 90 to 100, 100 to 110, above 110. But then again, this is arbitrary. However, we know that the higher the blood pressure, the higher the risk for complications, obviously. And there is also a feature called isolated systolic hypertension, which means that only the systolic value is increased while the diastolic value is normal. And this is something that we may find especially in the elderly population. Now, again, going back to practice, we need a simple approach and a pragmatic approach. So we will measure systolic and diastolic blood pressure, and we will use both to define the cutoff values for a good control of blood pressure and a proper definition of the global risk. So, steps for the diagnosis of hypertension. First of all, establish the existence of high blood pressure levels. And here we've already discussed the way we measure it, we repeat it, we do all those things in order to make sure this is present. Secondly, very important, identify, if you can, possible causes of secondary hypertension if there is a suggestion based on the clinical picture. I will get back to the secondary hypertension issue, and we will talk more about that tomorrow. Finally, assess the overall risk by looking for other risk factors and for target organ damage. So again, hypertension is very important, but it is not isolated. It is not something that you can evaluate as a standalone thing. This happens in a patient, and the patient happens to have other features or not. He may have other risk factors, he may already have organ damage, and you need to be exhaustive in your assessment and make a comprehensive assessment. So basically, you will do repeated blood pressure measurements in order to ascertain the first point here. Medical history, physical exam, and laboratory investigation will allow you to see whether the second and the third point here are properly answered too. Now, what about medical history? I was telling you this is crucial, and it's very important, especially for you as students. And it's very important because it's establishing a human rapport with the patient, and also it's not expensive at all. It doesn't cost anything. So what are the questions we will ask and the thing we'll look for? First of all, if there is family history of hypertension, if there is a personal history of hypertension in the patient itself, whether there is already cardiovascular disease, history of stroke, or renal disease, all of that is important. Family and personal history of risk factors, for example, hypercholesterolemia. Smoking, extremely important. Diet, what the patient is eating, how much salt, how much alcohol. What about the physical exercise? Is it rather a sedentary person or an active one? History of erectile dysfunction. This is important because this tends to relate with endothelial dysfunction, which may be a common mechanism for both. Sleep history. Again, this is important and is often overlooked. Doctors forget to ask about this. If the patient is snoring, sometimes you may ask his wife or his partner, because snoring is often associated with the sleep apnea. And of course, if it is a pregnant lady, we will ask about the previous pregnancies and the blood pressure during previous pregnancies and so on. Other things relate to hypertension-mediated organ damage, cardiovascular disease, stroke, and renal disease. And here we have the key organs: brain and eyes, heart, kidney, peripheral arteries. For each of them, you have a number of symptoms that the patient may describe or you may wish to ask. And this may represent target organ damage related to hypertension, or of course it may also be unrelated, but it will nevertheless be important that we find out this information. Now, a few words about secondary hypertension. I told you that most of the patients who have hypertension have so-called essential hypertension. That means we did not identify a secondary cause. This is about 90% of cases, okay? So a minority of cases may have secondary hypertension. That means that in those cases, hypertension is due to another cause, is secondary to that other cause. And this is important because if we identify a secondary hypertension patient, we may wish to treat the cause, and if we do this timely and properly, this may sometimes even lead to curing hypertension, which is otherwise very uncommon. Or in any way, it may lead to an easier control with less hypertensive drugs used, and so on and so forth. So it's extremely important. What are some hints pointing to a possible secondary hypertension cause? For example, if there is a young onset of significant hypertension, the patient is young, below 40, and has hypertension, this is a bit unusual, although nowadays is not so uncommon. Or sometimes sudden development or rapidly worsening blood pressure in an older patient. And then you can also go by the causes of secondary hypertension that we know: renal causes, urinary tract disease, some substances that may relate to high blood pressure values, corticosteroids, nasal vasoconstrictor, chemotherapy, and so on. Some features pointing to a possible pheochromocytoma. We'll discuss more about that soon. Sweating, headache, palpitations. If patient has hypokalemia, which is very significant, and episodes of muscle weakness, tetany, those may suggest hyperaldosteronism. symptoms that suggest thyroid disease, and of course, in the setting of pregnancy, in the setting of sleep apnea. Then you move from history to the physical exam. First of all, you look at the patient. Body mass index is very important. I told you about the importance of obesity, and we need to quantify this by measuring weight and height and calculating body mass index. When it's above 30, the patient is called obese. We need to measure the waist circumference, which relates to abdominal obesity, and it's an added risk factor. And then you look for signs of hypertensive-mediated organ damage, again, at the main organs that I've told you. Neurologic examination, because we assess the brain. Fundoscopic examination for assessing the eye, looking for hypertensive retinopathy. The arteries, we look at the carotid arteries and look at the peripheral arteries. Auscultation of the heart. And again, I'm telling you, comparing blood pressure in both arms at least once, because this may be diagnostic of a subclavian artery stenosis, if it's a significant difference, above 20 millimeters of mercury difference between the two arms. Other features of physical inspection, physical exam, you look for café au lait in pheochromocytoma and neophilbromatosis, kidney palpation. Sometimes you may palpate a polycystic kidney, may not be quite often, but sometimes it may happen. You may find murmurs across a narrowed vessel like the aorta in aortic coarctation, or you may find a murmur when a patient has renal vascular hypertension. You need to compare the radial versus the femoral pulse, because this is an important sign in aortic coarctation. And then you can look for signs of endocrinological problems, acromegaly, Cushing, thyroid disease. So we've discussed history taking, physical exam, and then you move on to the workup and lab tests. And the lab tests relate both to risk factor, to secondary causes of hypertension, and also to things that are important for the treatment and for selecting the drugs and for monitoring the effects of those drugs. So we'll do basically a regular test, hemoglobin, blood glucose, lipids, potassium, sodium, renal function, liver function, and urine is very important to look for the presence of proteins in the urine. 12-lead ECG belongs to the basic routine workup that will need to be performed in every hypertensive patient. And again, looking for hypertension-mediated organ damage, as I've told you, you use a number of things. With the ECG, you can screen for left ventricular hypertrophy or atrial fibrillation or tachycardia and things like that. By looking at the urine albumin to creatinine ratio, you will be able to identify signs of possible renal disease. Again, blood creatinine, not only urine levels. Fundoscopy, we have already discussed, you will identify retinopathy. Then there are a number of other tests, more advanced, which you may not necessarily do in every patient. Those may belong to a second line of assessment that may be performed by the specialist and not by the general practitioner. Again, in the same line of thinking, that is looking for hypertension-mediated organ damage. Echo for the heart structure and function, carotid ultrasound for the carotid arteries, plaques and things, abdominal ultrasound Doppler studies for the kidneys, both in terms of structure and function. Pulse wave velocity, this is very important, then it may be a sign of increased aortic stiffness that we know relates to prognosis in these patients. Ankle brachial index, this shows you if there is evidence of lower extremity arterial disease, cognitive function testing to look for brain damage, and the same line brain imaging. So just a few examples of some of those. So you see here there's an ECG, and you see, first of all, there is sinus rhythm. You see there is a normal heart rate closer to the bradycardic range, perhaps around 60, 55 to 60. We see that the QRS axis is normal, and we don't see much of changes, so this can be interpreted as within the normal range. So you may find this sort of an ECG in a patient who has hypertension, but the hypertension, if you find something like that, either it is not very long standing or not with very high blood pressure values. So in other words, you do not find evidence of left ventricular hypertrophy on this particular ECG. The opposite, you may find something like that. This is uncommon, fortunately. And again, you see sinus rhythm, but here you have evidence of significant left ventricular hypertrophy, both in terms of QRS voltage, very tall R waves here, but also in terms of STT wave changes. So whenever you see that, you know that the patient has significant LV hypertrophy, and depending on the blood pressure values, this may be due to long-standing hypertension. And you know that I will not go into detail because you had lots of discussions about that during the practical sessions. We have criteria to define LVH. The simplest ones relate to the voltage, but they also may have some features related to a lower sensitivity. And then you may have combinations of S and R. And these were described many years ago, very many years ago, as you can see. The advantage is they are simple. The problem is that they are not so sensitive. Okay? So if you look here at different scores from simple to more complex ones, you see that the sensitivity of this to detect left ventricular hypertrophy is very low, is, so to say, the sort of accuracy that you flip a coin. You see it's below 50%. What does it mean, sensitivity? It means that the test will be abnormal in the patient who has the disease. Okay? So this means that whenever you have a normal ECG, you cannot rule out the existence of left ventricular hypertrophy. Okay? On the opposite, the specificity is very high. You see around 90, more than 90%. That means whenever you see important changes of left ventricular hypertrophy, you may be pretty sure the patient has left ventricular hypertrophy, right? So you need to keep that in mind when you think of the interpretation of the ECG in this regard. And in fact, echo and other imaging tests are much better because they measure directly left ventricular mass, so you know directly if the patient has left ventricular hypertrophy, as opposed to the ECG, where you just estimate based on the electrical signal, and you have these limitations. Now, this is a patient with hypertension, and the patient has mild left ventricular hypertrophy. You see the walls have 13 millimeters, 12 millimeters. The normal range is usually between 9 and 11. It also depends, of course, on the body habitus, on the gender. But anyway, this is mild left ventricular hypertrophy. But this sort of hypertrophy, because it is mild, it may sometimes not be picked up by the ECG. The ECG in this case may be in fact normal, so unable to detect LVH, but you can detect it with a more accurate test such as echocardiography. And this is another patient, and this time this is severe LVH, and it's also a moderated dilated left atrium. This sort of LVH will usually give you signs on the electrocardiogram. So we use echocardiography because it is accurate in detecting left ventricular hypertrophy, and we have ways of measuring, and we have some parameters that allow us to define the existence of LV hypertrophy, to define the geometry of the left ventricle. You will not need to know these values, but rather know the concept that if you wish to be sure about the existence of LVH, LV hypertrophy as a measure of target organ damage, you will not rely on echocardiography, but you will wish on electrocardiography. Electrocardiography may give a hint, but you will use echocardiography in order to detect it and to quantify it. Now, there are a number of factors that influence the cardiovascular risk in patients with hypertension. Again, the hypertensive patients, they also have other important parameters to look at. We know that men are at higher risk than women. We know that an older patient is at higher risk than a younger one. And then a number of cardiovascular risk factors that you already know: smoking, dyslipidemia, diabetes, obesity, and also some of the family history, premature cardiovascular disease, family history of early onset hypertension, early onset menopause. I told you that fertile women, they tend to have a protection, a hormonal protection that tends to be lost at menopause. So if there is early onset menopause, those ladies may be at a higher risk, and similar to the men of the same age. Sedentary lifestyle, psychosocial factors, stress, and so on. And then to look for hypertension-mediated organ damage, again, we have a number of features related to the vessels, to the heart, to the kidney, and again to the peripheral vessels. And we have a number of parameters that we can measure, and based on the measurements, we can define risk factors related to that specific organ. Finally, I think I just have a couple of more slides. We have a way of estimating cardiovascular risk and placing a specific patient into a specific risk category. In general, very high risk patients, that means those patients tend to already have signs of cardiovascular disease. They had a myocardial infarction, they have other sort of coronary or arterial revascularization, they had a stroke, they have an aortic aneurysm, they have peripheral disease. Or you have unequivocal documented cardiovascular disease on imaging. You find a significant carotid plaque on ultrasound or on angiography. They have diabetes with target organ damage, proteinuria, grade 3 hypertension. They have severe chronic kidney disease that you may quantify by measuring glomerular filtration rate. Or there is this score that I will show you in a minute, which categorizes a patient in the risk at 10 years, the risk of having a cardiovascular event at 10 years follow-up. So then you have high risk, which is a little bit below that in terms of the numbers. You will have the chance to look in more detail at this. And finally, moderate risk. This is a calculated 10-year score between 1 and 5. Hypertension is not so severe. In fact, many middle-aged people fall into this category. And finally, this is rather uncommon after some age. because it means you don't have any of the issues mentioned on the previous slide, and your calculated 10-year score is below 1%. And now let me just show you how this works. You can look for yourself on the web at the heartscore.org website. And this is quite simple. It's also color-coded. It makes it easier to understand, because green is best, dark red is worst. And you see there is an increment from lowest risk to highest risk with the progression in aging, the quality of smoker versus non-smoker, the level of cholesterol, and the level of systolic blood pressure. So it's very easy. If you have a man who is 55 and is a non-smoker, you can look at the cholesterol values and put it in his own category. You have these 5 classes here. And here you can have the systolic blood pressure. So you will immediately be able to categorize him and to tell him the amount of risk that he's exposing. And the nice thing about this sort of diagram is that he can see by himself the impact that quitting smoking, reducing blood pressure, and reducing cholesterol will immediately have on his own risk. He cannot decrease his age, unfortunately, but he can act on smoking, on systolic blood pressure, and on cholesterol, both through diet and also through medication. And then we have risk modifiers. Again, most of these I have already alluded to previously, some of which may be modifiable, some of which are just based on history and it's just there. And this is the last slide, also from the same guideline. You can see here, why was I telling you that the blood pressure is important, but it's not standalone? Because you may have a patient who has 140 over, let's say 145 over 95, okay? So this patient may be low risk if he has nothing else than that, or the same patient with the same blood pressure may be at very high risk if this patient, this blood pressure values come on top of established cardiovascular disease, or the patient has chronic kidney disease grade 4, or the patient has diabetes. So please note that the simple presence of diabetes already places the patient in a high-risk category. So this is why, in order to properly assess the cardiovascular risk of the patient, we need to look at the patient as a whole and look at not just the blood pressure values, but all the other features. So basically, this is the lecture on how to assess a patient with hypertension and how to risk stratify. And tomorrow, during the second lecture, we will discuss about secondary hypertension and, of course, about the treatment of hypertension.
Can I ask something, please?
Yes, please.
From what comes that decrease in blood pressure during night?
Well, I told you during night, the metabolic requirements of the whole body are lower. So then what happens during night is cardiac output decreases because there will be a decreased heart rate. The patient will be bradycardic. It relates to the resting state. The patient sleeps, no rush, no stress. So because of the decrease in heart rate, blood pressure will also tend to decrease. I showed you it's dependent on the product of cardiac output and peripheral vascular resistance. So the normal tendency and the normal response will be that blood pressure will be lower at night. However, if there are changes in these mechanisms, maybe the patient has altered vascular resistance, vascular stiffness, neural mechanism may be involved. It's quite complex, but what we know is that if you see an increase in blood pressure values during the night, this is abnormal and this relates to a higher risk of cardiovascular events.
Thank you.
It may also be a target. Sometimes if you see that, you may wish to give also some medication at night before the patient goes to sleep. So it has both a prognostic value to assess the patient, but also has some therapeutic implications.
Thank you.
So just a few things that I'd like to tell you, because I was told by my colleagues that quite often the presence at the webinars, at the practical sessions that you have in the morning is not suboptimal, but recently it became really bad. I understood there were days when there were like 10 of you or even less, and you are supposed to be 60. I mean, now let's say if you are divided in two, you are 32 in a, so you cannot be like 10 students. So I would like to make a few points. I think I told you before, but it's important for you to remember. First of all, those are compulsory. It's not something if I want, I go, if I don't. So let's remind you, when it was with physical presence, you had to be every day in the hospital and you had to sign that you are present. And based on your presence, you were allowed to enter the exam or not. So if you had at that time more than 5 absences during the whole rotation, you were not allowed to enter the exam and you had to build up for them. For example, you had an issue, you couldn't come. What you did at the time, you had to come during the weekend or during the evening and spend 3-4 hours with the doctor on duty. In other words, to make up for the days that you missed. Now, what happens? This is no longer possible because nowadays you cannot come and you cannot make up for those days that you've missed because there is no way. We cannot have you in the hospital. We barely have you for a week. So it's compulsory that you attend these seminars and the courses. And I guess it's pretty easy because it's easiest for you. You just stay in front of the computer. I don't think it's much of asking. However, it's your choice. If you choose not to, what I can tell you is we will see who is present. We will take notes who are absent, and those who will have 5 absences will not be let to enter the exam. You will have to then come back and you will have to do some other work in order to make up for this. So please take this seriously, because first of all, is not any sort of punishment. Is first of all, I think it's in your own interest, and then it's only fair for all of you, because there are people trying hard and there are people not attending. So there has to be a difference in this regard. Secondly, take it seriously and try to read and learn, because even if you are there and you just don't pay attention to what the colleagues try to teach you, you will not learn, and the exam will be a serious exam. You will not be able to pass it if you don't prepare good enough. But the first step to prepare is to do the simple thing, to be present at these lectures. So this is what I wanted to say. I don't have anything more to add. All of us, we are doing some efforts to adapt to this and try to teach you. I told you, if you have questions, ask, be proactive, try to learn. That's the thing we try to do. But at the very least, you should be present. Otherwise, nothing can be built on that. So this is my request. Okay.
Thank you so much, Professor, for everything.
Thank you.
I see now you are 60.